welcome everyone. Today we're going to talk about aortic regurg in the critically ill. Why is the recognition of aortic regurg important to us as intensive care physicians? And I apologise for starting this again with pressure volume loops, but just briefly, patients with acute aortic regurg, they're super sick. They come to us often in extremis because they've got a massive regurgitant volume in an untrained LV. They shift towards the right in this pressure volume curve, and therefore they have elevated pressures in the left atrium with congestion, as well as cardiogenic shock with low forward stroke volume. So clearly an important group to spot, and often they need urgent surgical intervention. The chronic AR groups, they might be asymptomatic in the community until they then come to the ICU, and we give them fluid, vasopressors. They have some, sepsis, mechanical ventilation. All of these things can just tip this precarious group over the edge. And someone that was previously compensated with relatively, sort of normal filling pressures can then sort of tip over and develop congestion and features of shock. And as we know, these patients have clinical signs that we always need to corroborate with echocardiography, things like Austin Flint murmurs and wide pulse pressures and all of that. But echo can be very, very useful in this patient group, and I hope to show you that as we go through. So we'll go through anatomy, mechanism. I know some of you are new to this, so we're going to hopefully take it quite systematically, go through things fairly methodically and hopefully not too quickly. But we can always do another session if people feel like they haven't really got their head around it. Hopefully we don't run out of time, as I always do. I want to talk through some of the key differences then between, especially, I think this is especially important in ICU, is the differences and challenges of acute AR. And then we'll finish off with some cases. Please ask questions as we go through. So briefly, the anatomy, the aortic valve is a tricuspid valve. The leaflets are usually thin and mobile, joined by, the edges of the commissures. And the right coronary artery comes off the right coronary orifice. The left coronary artery comes off in the left coronary orifice. The aortic valve and aortic root are inextricably linked. And so when we think about aortic regurg and the pathology of that, we've really got to think about the cusps as well as the aortic root, which we'll come on to. Can I have a volunteer, however, to just go through this top left and just tell me if I put can you all see my pointer? Yeah, what cusp would this be, where my pointer is here? This one.
Left or none?
Right coronary cusp.
Nice hair one. Yeah, and how about this one?
That's right.
Very nice. Yeah. And how about if I put my pointer here, which one's this one? This is short axis at the level of the aortic valve. Just put it here.
Right.
Non.
Yeah, we have right and non. What's the consensus? This one here. Maybe I'll come to the zoomed view and I'll put it here.
It's a non-coronary cusp next to the interatrial septum.
Perfect, lovely, and that's how you orientate yourself, right? So that's really nice here, one. So we've got the interatrial septum here of left atrium, right atrium, and then next to the non-coronary is the interatrial septum. What does Chris Duncan say, who I have to thank for sharing some of these slides with me? He says the non-coronary sits on the fence, so that's quite a nice way to remember it. And then you've got the right, the right ventricle, the outflow tract here, so that's going to be the right coronary cusp, and then the remaining one is the left, next to the left atrium. Nice, and that's just a zoomed in view showing the right coronary cusp and then the non or the left. So you can't tell whether you're looking at the non or the left just from looking at it in the longitudinal plane or the long axis view. And that's the importance of obviously orthogonal imaging. What are we looking at here then? So what view is this? And what it says what we're using, obviously it's TOE imaging. What view would this be, Hewan?
So that's Mid-esophageal long axis view of the aortic valve.
Lovely. Yeah, at 120. Yeah. And what?
120, yeah.
Yeah, and what
So
cusp
that
am I?
so that would be that's the right coronary cusp.
Very nice. Yeah.
And then I'm again superior in the screen. I think it's either left or non.
Yeah, nice. And usually we would drop biplane through, hey, and then you can sort of get it real time. But again, what's this cusp here where I've got my pointer, Umi?
Left. No, that's the non because it's next to the interatrials.
Yeah, nice, very nice. So we've got again in toe, it's sort of flipped round, isn't it? So we've got the intraatrial septum. That's how we know that this is the non. And then we've got the right coronary cusp and the left coronary cusp. Very nice. All right. So as I said, when we think about aortic regurg and the mechanism or the etiology of that, then we need to think about the cusps, which can be that they're either degenerated, they're bicuspid, maybe you've got rheumatic heart disease or there's a big vegetation on it like endocarditis, or it can be about a disease that's affected the aortic root. And we'll go through the different types, but usually, the things that cause acute severe AR tend to be like dissections. Obviously, other things can cause it too. But yeah, chronic hypertension, because you're going to get that effacement and dilatation of the aortic root. Bicuspid valves tends to have that aortopathy and dilatation. You can have collagen disorders, traumas. I guess certain types of VSDs can, suck the one of the aortic cusps into it, and therefore you get a type of AR with VSDs as well. So a few different etiologies to think about. This is an excellent paper. You can scan that and look through it, but it's essentially if you want to know all about the mechanisms of AR in more detail, this paper's the one. It's really quite excellent. The aortic root is made up of the annulus is it's not a true structure, is it? But it's where the cusps sort of join the septum and the continuity with the aortic mitral curtain, and that's the aortic annulus. And arising from the annulus is the commissures, and they then join at the sinotubular junction at the top there. And then that wider part, the sinuses of Valsalva, allow the commissures to come in and obviously not squash those coronary orifices, so you still get blood flow in diastole. Measurements of the aortic root, I think, always cause a little bit of confusion, and I think that's because it's different depending on what guideline you read. So, I mean, the British guidelines suggest we're doing this in you do end diastole and inner edge to inner edge, or is it mid-systole inner edge to inner edge? I forget, maybe it's mid-systole inner edge to inner edge in the British guidelines. Anyway, the ASC guidelines suggest end diastole and doing that leading edge to leading edge, and I think a lot of the prognostic data is maybe based on that. As you can see, like this is an imperfect measurement, isn't it? This is transthoracic zoomed in, you can't really clearly delineate the edge of the edges to the interface with the blood, and it's not a perfect measurement. So, you might be out by a couple of millimeters. It is important to be perpendicular to the axis of the aorta when you're making these measurements. Sometimes you get really crisp imaging and it's easy. And we use the leading edge to leading edge method in our lab. We follow the ASC guidelines, but just to be mindful that there are those differences there. In terms of this like abnormal to normal, I'm not going to go into too much detail because I think it's been talked about in the aortopathy section, and also you need to go into it in a little bit more detail, but essentially you need to correct for sex and body surface area, and there's the nomograms in the ASC guidelines that you can look at, and that's referenced there at the bottom. But as you're getting towards sort of 3.5, you're thinking that's probably getting to the upper end of normal, and this is usually at the sinuses of Valsalva that we're talking about here. But yeah, you always need to check the nomograms and correct for body surface area when you're doing these things. Generally, surgery, depending on what the pathology of the dilatation is, if it's someone with Marfan's, you might do it sooner, but surgery tends to happen when it gets above 4.5 centimeters. or 5 centimeters, again, depending on the clinical circumstance. So just have a bit of an idea of what, when to start getting concerned, but you always need to double check on the nomograms for dilatation. So aortic valve morphology is obviously important. That's going to predispose to either stenosis or to regurgitation. What do we think of this aortic valve?
The opening doesn't have the triangular shape, so it's a fusion of one of the rough.
Yeah, very nice, Umi. So what would you say about this valve then? What do you think it is?
It looks like it's bicuspid, but I think it's really morphologically bicuspid. It's probably it is a fusion of the raphe of depending on toe versus transthoracic to decide what kind of raphe.
Yeah, very nice. So this is a transthoracic. So what do you think? What cusps might have fused?
I think it's the left and the right.
Very nice, lovely. And is that the most common, do you think?
Probably, yep.
Yeah, it is. About 70% of bicuspid aortic valves, it's going to be your left and right cusps that fuse. So that's really nice. So I might just slow that down. So it's often easier to spot these in systole when they're open. And then you can see that elliptical shape going from sort of a left to right orientation. And you've absolutely got fusion. So this is it's a TTE image. You've got your intraatrial septum down the bottom here. So you've got your left and your right commissures have fused. And you have a raphe at about the 2 o'clock position. And there's just one raphe, isn't there? That's resulted from the fusion. So nice, Umi. So bicuspid valves, there's various different nomenclature and things. I think, practically the important thing to talk about is what leaflets you think have fused and what orientation it's in. I mean, you can talk about type 0, type 1. This is the Sivers classification. And you will need to know this from American exams. I don't think they'll quiz you too much on Sivers classification in the DDU quick care. But essentially, if you've got no raphe, that's a true bicuspid valve. And you can either be in the sort of lateral or the AP plane, depending on the alignment of that. And then type 1 is where you've got fusion, type 1 raphe. And as I say, 70% or so is most commonly left and right fusion. And then sometimes you've got 2 raphes. So that they're the different types of bicuspid to be aware of. We can maybe talk about that in another session. Does anyone know what this is?
Leaflet.
What's that? Sorry.
But I don't know what's the word, but there's 4.
Yeah, that's why. Yeah. No, very, very nice. This is a really rare quadricuspid valve. So whenever you have an aortic valve talk, you always try and get that in. So we talked about obviously the different etiologies that you can have causing AR, and the way that we tend to then divide that up in terms of the mechanism is this type 1 to type 3 sort of classification. And it sounds hard to remember initially, but then it's actually not too tricky once you get your head around it. So type 1, you've got normal cusps. Type 1 A, B, and C, you've got normal cusps, that you've got the aortic root dilatation, and there's different patterns of aortic root dilatation that make up A, B, and C. So if you've got the whole thing being dilated as in A, then that's a type A, and then you get failure of coaptation, and that's the mechanism of the AR. In type C, you tend to just have dilatation of the sinuses of Valsalva. And then in type 1D, that's where you have cusp perforation. Okay, and then type 2 is where there's prolapse, so excessive motion of the leaflet. And then type 3 is restricted motion of the leaflet. So with that in mind, again, that's that nice paper I was referencing about mechanisms of AR. But what do we think could be going on here? So this is you put the toe probe down, you've zoomed in your long axis of the aortic valve, and this is what you're seeing. What do we think about the measurements of the sinotubular junction is 40. Sinuses of Valsalva are smaller than the sinotubular junction, which is unusual. And the ascending aorta is 43. Is it dilated or not dilated? All of this. You can say it depends on the body surface area and the sex of the patient stuff, but it's dilated, isn't it? I mean, it's going to be dilated in even those with the high body surface area if you index it. So what do we think how do we think the AR might look in this patient? Do you think it would be are you expecting to see any AR, like if you see a dilated aortic root like that?
Yeah, so you would just see a central jet, I guess.
Yeah, nice. And that's what you'd be expecting. So if you went down and saw this 2D image, like you're thinking, no, that looks dilated, let me measure it out and then let me put some color on and see where, if it's a central jet. And sometimes you still get eccentric jets depending just on, the exact coaptation of the cusps. But generally these tend to be more central jets. And this was the jet of that patient. So you can see quite a broad sort of central jet with flow convergence, which we're going to talk through, a fairly wide vena contractor. I can't remember what it was. I think it was in the moderate category, actually. And then you've got jet expansion in the LVOT. Okay, how about this one? Same view on toe.
Again, it's dilated, isn't it? Like, I'm sure it's
Yeah.
about sub of 6.4.
Yeah, it's huge. And yeah, and the sinotubular junction is also probably dilated, even though it is tapering off, isn't it? So again, expecting maybe to see some aortic regurg with that. What else do you notice, just out of interest, on this loop? What's anything else that you spot going on?
There's something. Oh well, there's probably a metal metal device within the RV.
Yeah, I use the pacing wire, isn't it? Probably, but it's hard to tell. So this would be that type 2B, where you've got, all of it dilated and the sinuses of Valsalva. All right, what do we think of the mechanism here then? Does someone want to comment on, describe what we can see in this left-sided picture here, loop?
I think there are like multiple, well, at least two, like eccentric AR jets with flow convergence. On the left, on the color Doppler.
Yeah, and how about the 3D?
And I think there are like, it's suspicious for leaflet perforation, like particularly in I'm not sure what leaflets those would be in 3D, but like the top two leaflets look a bit suspicious. Oh, is that the interatrial septum?
Yeah.
Okay, then I guess the non and right.
Nice. It was the non-coronary cusp. You can see here in 2D has leaflet perforation. And just going back to that color then, I mean, that just looks horrible, doesn't it? It looks really broad, there's lots of turbulence. Flow convergence, probably multiple jets. You can't really see the flow convergence because you're getting a little bit of dropout, through where the vena contractor would be. But just eyeballing that color, in terms of the jet width, compared to the LVOT height. It's obviously subjectively it looks more than 65%. And then the mechanism, you've got a actual defect in the leaflet itself. So you're already thinking, could this be a severe regurgitation associated with the 2D defect? And then of course you would go on to check more things and try and grade the severity of that, which we'll come on to. All right. I think this might be the second to last one in terms of mechanism. Can anyone give me the mechanism of this person's aortic regurg? You've only got 2D in this one plane, so I'm being mean, but I think you can spot it. And this would be fair game to show you in a Viva and expect you to get this, I think.
So it looks like there's a prolapse of the right or the left coronary cusp.
Which one? Yeah, what cusp is it? You can be quite certain about this one, this cusp.
Anatomy not that great, so it would be a right coronary cusp.
Yeah, very nice. And then this top one is either your non or your left. You got your right, your RVOT here. So you know that that's your right coronary cusp. Very nice and lovely. Yeah, can you see how that's prolapsing? So now, just based on that, what direction do you think that the regurgitant jet is going to be heading? Towards the sort of septum or towards the anterior mitral leaflet?
So if prolapse, it should be in the opposite direction of the prolapse, so it should be towards the mitral leaflet.
Very nice. Yeah. And we can see that here. Sorry, I'm covering my screen, but can you all see that? Is it only me that can't see it? Can you see it? You can see?
Oh.
Yes. Oh, no?
We can see the bottom color as a still.
Yeah, just as a still. Yeah. Showing that flow I can't see it, but I think it shows a flow convergence just behind the right coronary cusp. So that's the origin of the jet. And then you'll see the vena contracta and then the direction, heading towards the anterior mitral leaflet, and looks really broad and quite severe. All right. I think one more. Mechanism, what this one might be. Just focus on this part here. I know there's this artifact in the aorta that's quite confusing. You might think it's a dissection flap, but it's not. I think Sam did a recent session, didn't he, on aortopathies? They probably spoke through how to differentiate artifacts from things like that. Does anyone just describe what you see of these leaflets? Anyone want to describe the cusps here? Do they look normal and pliable and like they're opening nicely, or do they look a bit thickened and restricted? Yeah, so they're quite thickened and restricted, and this maybe has like that systolic doming, or maybe not, that you sometimes see in rheumatic aortic valve disease. It's often less well described, I think, because we always think of that diastolic doming of the anterior mitral leaflet. Well, in aortic rheumatic heart disease, you get that systolic doming of the leaflets, and I don't think that's what's happened. There's a little bit of doming there, but anyway, I'm not sure what the pathology of this patient was, but they've certainly got restriction of these leaflets, and you can see nicely in 3D how they're just not coming together. There's a failure of coaptation in the center, with some central aortic regurg there as well. All right, so that's thinking about mechanism. So don't just think about the cusps themselves, think about the aortic root, and think about what's driving the severity, the AR. As always, I'm not going to cover everything, and you will need to do your own background reading. Obviously, the guidelines is ASC, the BSE guidelines on this are excellent as well. Actually, I'd recommend checking those out. So you're probably familiar with this table, for those of you that have started sort of doing advanced echo stuff. And we're going to go through this in a bit more of a structured way. All right, so we'll come back to what all of these things mean, because I think it can be a bit overwhelming when you first look at these tables. So we'll start with 2D. All right, so 2D imaging. We're going to be, as I said, looking at the morphology of the valve, if there's any obvious abnormalities like a big flail or prolapse or a huge dilated aortic root. And you can get us so much information just from your 2D imaging. Obviously, never rest your laurels on one view. You're going to always look in multiple planes, different angles, really interrogate all of your 2D imaging. And what we can see down here is that's what I was talking about with that systolic doming. So this is a patient we had with rheumatic heart disease, with restriction of the leaflets. Can you see how there's doming of the leaflets in systole? It's actually quite nice. Obviously up here we have a big 2D defect of both the aortic and mitral valves with huge vegetations there. So we'll be expecting to see, you know, severe valvular regurgitations associated with those. And just notice that the LV, I mean, you can't really see it, but it doesn't look terribly dilated, doesn't it? It looks like the function is hyperdynamic, which is classically what you see in acute aortic regurg, that you haven't got that remodeled LV. So you often have a normal LV size with normal to hyperdynamic systolic function. A common question in exams might be, you know, tell me how you differentiate acute from chronic AR. And so I'd like you to come away from this session if you know, that's one of the main take homes, really, like things that we look for to differentiate acute from chronic. So that's one of the things is lack of chamber remodeling in acute AR. So you tend not to see that big dilated LV and left atrium like you would in chronic. This is a patient with chronic aortic regurg. The mechanism is what? Can anyone hazard a guess just from this view?
It's just a massive aorta.
Yeah, exactly. Yeah, very nice. And clearly it's been going on for a while. They get this eccentric remodeling, don't they? With this spherical shaped LV. Yeah, very nice. So 2D, you know, I think we all can rush a little bit when we're starting to move from that basic to more intermediate and advanced level to, you know, hurry to want to put color on and you know, do multi-D imaging and you know, use Doppler and things, but there's really, you can get a lot of information in your diagnosis, you know, a lot of the time from 2D, obviously not severity, but you can get a pretty good idea that you're going to be dealing with severe if you've got a big flail leaf flow or something. It's not always the case, but generally it is. Color Doppler. So again, just the basics is that we tend to do this, I guess, in the you know, the parasternal long axis, which, I mean, this is the toe image, but putting the color box on there, making sure your scale, you know, is between 50 and 70, that you've got your settings right on that. And we'll go through the different components of the jet that you're looking at. But just to pause this is someone with mild aortic regurgitation. In fact, I think it's that rheumatic heart disease that I showed you on the last slide. And it's always good to slow these down and looking at the jet in diastole. Okay, and what I'm asking myself here is there a big flow convergence? Does the vena contractor width look significant? And I tend not to, in AR, I tend not to look too much at the jet area because you get unpredictable broadening of the jet because it's entrained in your LVOT. And so you can really, you know, be going down the wrong garden path if you're just looking at that, you know, the jet broadening an area. But you can use it in sort of a semi-quantitative way, I suppose, when you measure it out against the LVOT size. But there are some caveats of that to be aware of, which we'll go through. So is everyone happy that that's sort of consistent with a mild AR? You haven't got much any flow convergence zone really, or very small. And if I got the calipers out and measured that vena contractor, what is vena contractor actually? Can anyone give me a neat definition of that? What is the vena contractor when I'm saying that? So it's the neck of the jet, isn't it? So as you've got blood coming back towards that hole, you're going to get your Pisa forming. Then all of those cells are going to, you know, accelerate where you've got the highest velocity happening into a very narrow funnel, and they're speeding through that hole, and it's the narrowest portion of the jet of, you know, is the vena contractor. It tends to be relatively flow independent. So I, you know, as long as you can zoom in and be sure that you're getting a good vena contractor. I quite like vena contractor, just again to put pieces of that puzzle together. You would never hang your hat on a single value, but for that reason, and it's quite fairly easy to do as long as you've got, you know, you're zoomed in and you've optimized your imaging. It's quite easy to measure, and we'll talk through the different values of that. And then, you know, we put color on as well, don't we, in our apical windows, and this is our 5-chamber showing pretty severe looking broad. Why isn't that doing that? Sorry guys, just trying to get to play, but it won't. There you go. Again, that patient with chronic AR, severe aortic root dilatation with a very broad turbulent jet, looking quite eccentric and nasty. And we've gone to further quantitate that. So this is the patient with the infective endocarditis, showing very turbulent, broad, eccentric, nasty looking AR. It's just training your eye. I guess the more of these you see, then the more you just recognize that this is looking like, it's probably going to be severe. And then we need to obviously go on and quantitate it. In the 3-chamber color, showing mild aortic regurg, or what would be typical of a mild aortic regurg, mild to moderate. I don't know what the rest of the values ended up being, but we're not seeing much of a flow convergence, just slowing it down in diastole there so you can see it. You're not seeing much of a flow convergence. And it's not really the right angle to measure a vena contractor on, is it? Because you want to be ideally perpendicular to the jet to do a good vena contractor. I've already told you the answer to this, but would anyone use the sort of jet area, a bit like you do in mitral regurg, to sort of help you grade, and tricuspid regurg to help grade severity? Like how much it expands into the LV and how big that jet area is. I guess if you remember, one thing that I tell you today is don't use that as a marker of severity. You'll be up the wrong garden path. It's really unpredictable what happens to that jet area once it's sort of gone back into your LVOT, and you get all sorts of, expansion and entrainment. And you can really, overcall severity if you just are looking at that. So it's an important point, and they do emphasize that a fair bit in the British guidelines, especially about not using jet area to grade severity. And here we can see, in contrast to the mild AR, here we've got someone with severe aortic regurg, where we've got a significant proximal flow convergence. Can you all see that? This part happening here. That Pisa dome forming. We've got what looks like a really broad vena contractor, even though we can't see it too well because of all the calcification and dropout and things that we're seeing. And yeah, a severe looking jet. But again, don't just look at what's happening to the broadening there in the LV. Look at the other features of components of the jet. And I think the proximal flow convergence is often the most helpful when you're eyeballing the color Doppler. So they talk about this in these tables. So if we just go on to put some numbers in there. So I guess we can look at the jet width in the LVOT. Can be in severe, it's often large, but eccentric jets, you can really underestimate severity. So just be really mindful of that. And then just as we saw, as I was slowing down there, we have that small sort of small jet width in mild. Flow convergence is really absent in mild, or very small. In moderate, it's somewhere in between, severe and mild, which this isn't really that helpful, is it? It's all sort of qualitative. And then you get this large flow convergence, just like I showed you on that previous loop, in severe aortic regurg. And then we can use the different components of the color jet as in a semi-quantitative way, if you like, and we can look at the vena contractor width, which I'll show you some pictures of now. And if that's more than 0.6 centimeters, it's in keeping with severe. You can see that there's not much between mild and severe, right? We're talking 3 millimeters. So really emphasizes the importance of accurate imaging, trying to really optimize your images. And then the jet width to the LVOT width, which I'll show you how to measure that out, more than 65%. Is in keeping with severe, less than 25, mild, and then somewhere in between, mild to moderate, moderate to severe. And then you can also do it in the cross-sectional view, where you have your short axis of the aortic valve and measure out in diastole what the cross-sectional area of your jet, and then put that in proportion to your LVOT cross-sectional area. And if it's more than 60, again, that's in keeping with severe. I find that harder to do than the jet width, which is often quite easy to do. So these are the different components of a jet that I told you about. You've got your flow convergence here, your Pisa dome as it's coming through that narrow hole, vena contracta, which is the narrowest portion of the jet, and then you've got that, you know, the jet area or the flow expansion that happens, which can be quite unpredictable. This is how you would measure vena contracta. It tends to be best, especially for central jets, and eccentric jets, really, in the parasternal long axis view, but sometimes you can get better imaging, you know, if you've got, I don't know, COPD patients or something, and you have like a low down sort of 3-chamber and things like that. So just search for where you're going to get that best resolution and most accurate imaging. And then you put your calipers across the narrowest portion and measure that out. So this would be an example of someone with mild, moderate, and then not a great example, but you can imagine, you know, someone having a really a broad, like a wide vena contracta in severe. The thing about vena contracta, to measure it accurately, is that you do need to be able to see this proximal flow convergence. Otherwise, you don't really know like where you're putting your calipers to measure it. But in reality, you know, you don't always have that nice, beautiful flow convergence. It's often chaotic like this one, because you've just got rip roaring, you know, severe AR, and the anatomy of the valve and all of that can sort of, you know, mess up the textbook imaging. So yeah, just really what we've talked about. So make sure you're getting your measurements are as good as they can be. It's the narrowest jet diameter, you know, just proximal to the valve. You can use vena contracta in eccentric jets, which is probably a reason that I like it, because we see so many eccentric jets, and it's one of the things that you can use reasonably accurately on that. As I say, it's relatively flow independent, which is why I like it, you know, being an intensivist doing these things. But it's not that good, obviously, if you've got multiple jets, right? And as I say, you don't always see that flow convergence, so it can be hard. This is how you would measure your jet width to your LVOT width. So you can either do it in 2D like this one. So you would measure just downstream. You want to be just downstream of your vena contracta, but within 1 centimeter of the vena contracta. And then you would measure your jet width. And then at the same point, you measure your LVOT width. Okay, you can, if you can get your alignment right, you can, which I really like doing this, especially with toe, you can put M mode through that, and then it just gives you a nice, you know, you'd measure your LVOT width here, and then you'd measure your jet width there, which is quite nice. You can all appreciate that this is the regurgitant jet here in diastole. This is your LVOT, and then this is your, you'd measure the width there. And if it's more than 65%, it's in keeping with severe. Again, all these measurements have caveats, right? So the main pitfalls is that in central jets, you might actually overestimate severity, and in eccentric jets, you might underestimate severity. As I said, that AR jet does unpredictably expand below in your LVOT. So it doesn't always mean, you know, that you've got severe if you have got it over 65, but to be honest, generally you do. And then of course, if you've got someone with a really big LVOT, that's going to impact the, you know, the percentage values. So you just need to have a bit of common sense with that too. And continuous wave Doppler is what we can use, you know, as we sort of move on from using colour. And the density of the jet can give you that sort of subjective or qualitative assessment. So if you're seeing, so important that you're as aligned as you can be. And if you've got an eccentric jet, often that's in your parasternal long axis view. I think I've got some pictures to show you that. You know, your best alignment's not always in your apical imaging, especially with the eccentric jets. And if you're seeing a faint or incomplete profile, then that's more in keeping with mild. If you're seeing it very dense, and a nice trick to do when you're thinking about density is to compare what's coming, the density of the flow coming forward to the flow going back. And if they look similar, then you've you know, I quite like this as like that's a marker that it's probably heading towards severe. I know it's qualitative, but I do quite like that. I probably prefer that more than the pressure half time, to be honest. And then somewhere in between is moderate. So we can, as I say, you know, look at the density and also measure this thing called the pressure half time. Does anyone want to tell me what they know about pressure half time and what kind of values they would be thinking of when they're thinking about AR severity? Can all help each other out if you like. Any numbers that you want to throw out there, and then we'll talk about caveats of it.
Less than 200 is severe. 500 to 200 is kind of moderate, and more than 500 is like mild or normal.
Nice, Umi. And can you explain that, like why that would make sense that you would have a shorter or steeper pressure half time, you know, shorter pressure half time if you've got severe aortic regurg?
Just in terms of the acceleration of the blood going through, the velocity, this.
Not so much. What's it telling you? What's the pressure half time telling you? But is it like about the, so it's telling you about the pressure difference, isn't it, between your aorta and your LV, right? So, and how quickly that those pressures equalize, right? So if you've got a lot of blood gushing back from your aorta into your LV, the pressure between your aorta and your LV is going to equalize super quick, isn't it? Because you've got loads of volume coming back. So that's why a short pressure half time, you know, and the cutoff is around 200 milliseconds, is in keeping with a severe AR. However, what are some of the caveats to that then? Might just bring you onto this slide. So this is what I'm talking about here, right? So if you've got just a small volume of blood coming back, then you've got your aortic pressure here, right? And your LV pressure here. If you've got a small amount of blood coming back, you're going to take a relatively longer time for those pressures to equalize up. Whereas if you've got severe, this line's going to be super steep, isn't it? And your LV and your aortic pressures are going to come together and equalize more quickly. Yeah, so that's really what this is where sort of pressure half time comes from. But can you think of any reason apart from the volume, you know, the regurgitant volume, which is how we're quantifying the severity of the AR, aren't we? It's like how much regurgitant blood is going back in mils. But what other things apart from that, if you look at these two pressure time traces, you know, your LV in pink here and your aortic, you know, your art line tracing in blue, what other things would bring these two pressures together quicker, apart from just the volume of blood? I think people misunderstand this actually, so I think I'm going to spend a little bit of time just emphasizing this.
I mean, like loading conditions, like afterload?
Yeah, absolutely. Definitely. Yeah. So what things might that be here on? So
yeah, so like using vasopressors, I guess would do that.
Yeah, especially like hypertensive agents, like dilators, right? So if you're going to bring your aortic pressure down, then that LV pressure and aortic pressure are going to meet more quickly. So that can shorten your pressure half time. Doesn't happen that often, I suppose, that we might start put like systemic vasodilators though, mightn't we, on someone like this to try and, I suppose, reduce the regurgitant flow and increase forward flow. Like if you had a hype, that's why in aortic dissection we give them, you know, those medications, because we want to reduce the regurgitant fraction, and we obviously want to protect the shear forces on the dissection flap, but we often therefore, you know, increase the forward flow, reduce the regurgitant fraction. So there's that, but there's also, imagine someone with a really stiff ventricle, so they've got reduced LV compliance. They're going to be, their LV end diastolic pressure, which is here, right, is going to be shifted up there. So they're going to equalize with their pressures. Aortic pressure and LV pressure is going to become, you know, together sooner, isn't it? So anything that puts your LV end diastolic pressure up is going to shorten that pressure half time. So that's why you can't So you might, for example, then, so a clinical example of that would be a patient with significant diastolic heart failure, diastolic dysfunction, and a stiff ventricle who has moderate aortic regurg, but who also has a pressure half time of 180 milliseconds, right? And it's not the volume of blood that's causing them to have that pressure half time, but it's the fact that they've got raised left ventricular and diastolic pressures, that are causing that more rapid equalization of pressures. So the problem as well with pressure half time, there's obviously the loading conditions there, but it's also, as you can see here, right from this tracing, it's kind of different on every beat. It's a bit fuzzy at the top, it's not, and this is obviously a real life patient from ages ago, actually. But anyway, where do you exactly measure that? So it can be a little bit tricky, like from that perspective. It doesn't always look like the textbooks, but you get the general impression, you're putting that together with the density, similar to what's going forward, with the color Doppler, with the 2D defect, and you're starting to paint a picture, of this is severe aortic regurg with all of that together. As we always say, never hang your hat on one thing, but seeing the whole heart together. And it's probably chronic aortic regurg. This would be an example of someone with acute severe aortic regurg that has, can you see how you've got a really short sort of premature diastolic sort of spectral profile there, because it's just shooting straight back into that LV, which has got a high end diastolic pressure because they're in acute cardiogenic shock, and that volume of blood is just going back as well. So you just get this sort of triangle shape, and pressure half time, if you want to measure it out, it's like 90. It's just very, very steep. You almost don't need to measure it out, do you? But it can be easy to miss. I'm going to show you a case. And then this is the pressure half time being measured out on a transesophageal echo. What view are we likely to be in there? Here one, for this one on the right.
So it's deep gastric, LV, I don't know what the view's called, but like deep gastric and LVOT view.
Yeah, very nice. Yeah, and that's often a night, like if you're not getting good TTE images, but you really need to interrogate that aortic valve, moving to toe is important, and is an option for you to try and quantitate better. And often you get nice alignment either in your deep transgastric or in your transgastric at the sort of 120, where you get that, Sam says, the second bite of the cherry with interrogating the aortic valve. So I think we've spoken about most of these sort of pitfalls and tips for doing pressure half time. For us, I think, is in intensive care, being mindful of this bottom one, the things that I've just spoken about, is very important, especially when you're just starting off and you're sort of, I think when you are just starting, we do tend to sort of want a bit more quantification, like with numbers and things. We can fixate a little bit on numbers. So it's just really important to be aware of the caveats of pressure half time, as well as the good things about it too. Pulse wave Doppler. All right, if I give you an option to use pulse wave in someone with AR, where would you put your gate? Where would you want to sample to help you with severity assessment?
Descending aorta.
Yeah, very nice. Why is that, here one?
To look for flow reversal, whole diastolic flow reversal, which is a feature of severe AR.
Very nice. And do you have, and if you see that in the descending, it's a lot more specific, isn't it, for severe AR? But if you see it in the descending, sort of just proximal to the subclavian, we'll look through these. Do you have any velocities in your mind for like when you would think about severe there as well? Because it's not as good as having it in the abdominal aorta, is it? When you see it in the abdominal aorta, you've probably got severe AR, because it has to travel all that way, right? Come back, like it's pretty severe. But do you have any velocities for?
Is it 0.2?
Yeah, very nice. Yeah. 0.2 meters per second or 20 centimeters per second. Yeah, along the side, which we'll come to. So this, if it can be normal to see a brief early diastolic reversal just because the elasticity of the aorta and stuff. But if you see this prominent hollow diastolic reversal, that's in keeping with severe, especially in the descending aorta and especially in the abdominal aorta, I should say, more than the descending. But and then in between, right, is moderate. So these moderate to severe ones are always quite tricky. So this is how you might do it with transthoracic. Your suprasternal view is good for this. With the probe marker about the 1 o'clock position, you get this nice view. It's actually easier than you think. You can usually get it in most patients, even when they're vented and things. And then you've got to look for you've got your innominate vein there, and then you've got your branches of the aorta, and then you've got to go distal to the subclavian, which is here, and put your pulse wave just there. But use colour to help guide you. And then you're going to pulse just down there, and then you'll see, so before you pulse, obviously put colour on. What does this show? So we've got this is your aortic valve here. You've got your aortic root, your aortic arch, your branch vessels coming off. And then this here is just the proximal descending aorta. What can we see here? Does anyone want to comment on this loop? Is it normal? What would you normally see? Blue blood or red blood? It's funny, I just had like my blue, yeah, nice. I just did some questions for you have to do your recertification for your American exams and stuff. And the first question I got was this view, suprasternal view with just color on, and it said, is this normal? Is this coarctation? Is this aortic transection? And it was just a normal. That was the question. It was just normal blood flow. So it was just recognizing what's normal before you can come on to abnormal. So it's a bit mean of me to then show you this, because normally you would you would just see blue blood coming, right? And you might see a tiny little speck of red because you get that little bit of backwards flow just because of the elasticity of the aorta and things. But in this patient, you're seeing blue blood and then lots of turbulence and then lots and lots of red blood coming back. You see that? So this is someone with severe aortic regurg. And what you can do, which is quite nice, is you can either put M mode through that, which would look like this. This is not that patient actually, and the red would actually take up the whole hollow. So this is systole. So if I just drop M mode through that, I would see the blue blood coming towards the probe, right? And then that's in systole, and you get this lovely temporal display, don't you, in M mode? It's really nice. M mode with color on. So you have this systolic blood coming out, and then you have diastole starting here, and then you have red blood in diastole, so going in the opposite direction throughout the whole of diastole. This patient doesn't have it in the whole of diastole. This could be someone, for example, with acute severe AR, where it terminates early. Yes, it doesn't have to, it's not, and that's one of the caveats of acute AR versus chronic severe AR, is that you can get this early termination of the diastolic flow because of what we just talked about with the rapid equalization of pressures in that untrained left ventricle. So that's quite a nice thing to do. I quite like doing that. The other thing that you can do is drop your pulse wave gate in that, and you'll get something. This is toe, so just excuse it, but you'll get something that looks like this. And what we have is this is the distal descending aorta. That's where our sample gate is on toe. So we've got blood systolic flow coming away from the probe, and then we've got diastolic blood flow throughout the whole of diastole. Hollow diastolic flow reversal. And this is in keeping with severe AR, and I can't see the side markings, but I can. So it's around about that 0.2, 0.3 mark, I think. So this would be in keeping with severe aortic regurg. And this is just color on the descending aorta, which you can also then pulse with your pulse wave Doppler and see if there's any flow reversal there. If I had to choose one of these, I would choose to do this view and pulse that, because it's more specific. Like if you see it in your abdominal aorta, then it's likely to be severe. Whereas you can get some false positives, I think, sometimes in your suprasternal, especially if you're not quite distal to the subclavian and things like that. Yeah. This would be someone, for example, with maybe moderate AR that's got they've got flow reversal, so it's that intermediate, but it's not prominent and hollow diastolic. Yeah, so compare it to that one, to this one, non-honor. This is so this time we've got the sample gate for this patient in the abdominal aorta, so flow coming above the baseline towards your probe, and then diastolic flow reversal happening here, but non-hollow diastolic. There are other things, so the pitfalls of some of this is there are other things that can give you hollow diastolic flow reversal. So I guess would be a relatively commonish question. So AV fistulas, ruptured sinuses of Valsalva, etc. would give you that. You can also, for pulse wave, you could have answered your LVOT flow as well, because in severe AR you tend to see a higher LVOT VTI just because you've got that higher blood volume toing and froing. Right, so we've talked about all of them actually in that table, and we're coming towards the end. I've gone over it again, but if you're still unsure, right, so you've gone through all of these things and you're still like on the fence and you're really not sure, then we can use more, and we should be really all the time, quantitating as much as we can with echo before moving on to other things like, well, transesophageal or cardiac MRI and things like that. So this is from the guidelines. So we've talked about these specific criteria for severe AR, and if you've got more than 4 of these, then you're probably thinking it's likely to be severe. So all the things that we've just talked about, right? I'll not go over it again. But if you've got a few of them and you're still not quite sure, then we should be coming down and doing these quantitative techniques. And you can look at this in more detail in your own time. And these quantitative techniques, you've probably heard of them, but things like PISA and then the volumetric assessment. It's a bit of a talk in and of itself, but I'm going to try and do my best to explain it to you simply. So as you've got blood coming back towards the orifice, you get these PISA domes forming. And what we can do is reduce the color. So this is the color flow that we've zoomed in on. It's important to optimize your imaging, right? So you're going to zoom in on where you see that flow convergence. You're then going to reduce the baseline of your scale towards the direction of the regurgitant jet. So here you've got regurgitant flow going this direction. So you're going to bring your baseline down here between 20 and 40 centimeters per second. That's where your aliasing velocity should be set. Then you're going to measure your PISA radius, okay, called here the AI radius, aortic insufficiency radius. This is taken from the BSE guideline. And then you're going to measure, and people often get confused about the measurement and measure it like in the direction of the jet, in like central jets especially there, but you should be measuring the PISA in the direction of the insonation beam. So this white line would be where you measure as opposed to the red line, right? I've stolen all of this from the BSE guidelines. I hope I've referenced it. I don't think I have, but that's where I've got it from. And so then you get your PISA radius, right? And then you know what the aliasing velocity is. So then you can do, or the computer works out for you, right? It does. So you're going to take it from your vena contractor neck towards your first aliasing shell. So where the yellow goes towards the blue, all right? That's the radius there, or here to here, right? And then you're going to do pi r squared on that, and then times that by, then you're going to times that by your aliasing velocity, right? And the computer does it for you. And that gives you a flow rate of 75 mils per second. Then if we know the flow rate and we know the velocity, right? So flow equals area times velocity. We can then do flow over velocity, yeah, flow divided by velocity, and that gives us our effective regurgitant orifice area, which is not the same as the anatomical regurgitant orifice area, but it's at the point of, the vena contracta, and it's the thing that's prognostic for these patients, the effective regurgitant orifice area. And so if you have calculators, you might want to do it yourself. So if I do 75 divided by the velocity of the AR, and I get the velocity of the AR by doing continuous wave, right? Tracing it out and using my Vmax. Obviously you need, and these are some of the problems with it, right? You need to have perfect alignment, needs to be really good continuous wave. You need to be able to trace it out accurately. So there's these caveats to it, but this is how you would do it. So we trace that out. We do the maximal velocity. We divide that by our flow rate. So if you do 75 divided by 458, right, you're going to get 0.17 in your calculator, and that's your effective regurgitant orifice area, right? And there are some cutoffs that we can use for mild, moderate, and severe. And I'm going to bring you back to that here. So this is your effective regurgitant orifice area. Less than 0.1 would be mild, more than 0.3 severe, and somewhere in between moderate. So in this particular patient, 0.17 would be in keeping with moderate AR. So I think that's not too difficult if you're doing a tour, for example, in someone in the ICU and you've got perfect imaging. We can do that super easy. The machine does it for you. But again, just remember, with this Pisa radius, you're going to a tiny bit off. You're going to square that error, okay, because it goes into this equation here. You might be off with your alignment for your continuous wave. You might not get your Vmax quite right. If you've got an eccentric jet, you can still use Pisa, but it's more tricky, right? Because you're kind of in this sort of plane here, and where do you measure and all of that. And then if you've got multiple jets, obviously it's difficult too. So there are definite caveats, but I think working out the ERO is fairly easy, and 0.3 is the sort of number to remember for exams and things. Then you can go one step further and do, volume and things, and do. So if you've got your area, just like you do for LVOT stroke volume, right? You do the area of the LVOT times the VTI, LVOT VTI, and that gives you your stroke volume. Well, it's just the same for this to work out the regurgitant volume. You do your EROA, you times that by the VTI of this, which is 187. So if you do 0.17 times 187, it'll give you about 32 mils. All right, so that's how I think, I think sometimes I hear from trainees and stuff that, I don't want to do Pisa, it's too hard. It's actually not. It's really simple equations to remember. Yeah. And that's all it is. It's the caveats and when to use it and when not to use it that's harder, I think, than actually doing it. We talked about some of the pitfalls there. The other thing that you can do to quantitate is the volumetric method. So if you can, I'm going to really skip through this and I apologize, but I hardly do it usually because there's a caveat that prevents me from doing it, or it's just too hard to do because I think you need to be doing it regularly to be good at it. But essentially you can look at what's coming out of your LV, what's coming out through your aortic valve, compared to what's going into it. So if you've got a lot coming into it through your mitral annulus, and it's the same equation, your mitral annular VTI, sample get at the tip of the mitral leaflets in mid-diastole, measure out the VTI, times it by pi r squared of your mitral annular diameter. Yeah, so your mitral valves are open, you're measuring the diameter. You plug that into the equation that we use all the time to work out LVOT VTI. It's the same equation. That gives you a volume of what's coming in. And then you're going to look at what's coming out of your LVOT, and then the difference between those is your regurgitant volume. An obvious caveat, right, is if you've got someone that also has mitral regurg, you can't use this because it's going to stuff up this part of the equation. What you could do in that circumstance is measure what's your RVOT stroke volume. So go to your right side, do your RVOT diameter, your RVOT VTI, and then look at the difference between those two. And then you can work out your regurgitant volume that way as well. You can look at that a bit more. So in summary, this is what is in, and these are the things that you sort of need to remember for the vivas and things, like when they're asking you to comment on a patient that might have like a case that might be severe AR. These are some of the things that you might throw out there, which you can recap. Or just this 50-50 rule is quite a nice one that I like. So this is for chronic severe AR. If their ejection fraction is less than 50% and their left ventricular end systolic diameter is more than 50 millimeters, then that's probably like it's one of the criteria in the guidelines for needing surgery. So the 50-50 rule. And then it's a 60-40 rule for MR in the guidelines. So just quickly again, because this is one of the take homes, is differentiating acute from chronic, like know the difference there. So this comes up in exams all the time. So I'm just going to quiz you, right? This is a point and shoot. If you know it, say it. If you don't, then I can just tell you what it is. What are we looking at here? This is classic for American exams. They'll show you just a picture like this and ask what it shows.
It's early closure of the anterior mitral valve leaflet, which is like an indirect sign of severe AR.
Beautiful, beautiful. Yeah, so usually closure would be here, but it's the R wave and it's premature, right? So really nice here one. What does this show?
Diastolic MR.
Yeah, diastolic MR, really nice. And you can see that it here, this little bit of diastolic, this notch here, they love this in the DDU. Like it's such a favorite question. Yeah, it's like cherry on top. It's not pass or fail, but it's really nice. And then what's nice to do is color M mode as well, because this is it here. The diastolic MR is here. Because you get that nice temporal resolution. What's this one showing?
Fluttering of the, yeah.
Yeah, nice. I think this is what gives you like the Austin Flint, isn't it? I think maybe, I don't know. And then brownie points for this one. What is it here? What's this part?
That's just like aortic valve.
Yeah.
Opening in M mode.
Yeah. What's happening here though?
Like is it
like it's meant to
early?
Yeah, premature opening of your aortic valve because of that pressure, right? The pressure in your LV is so high, your LVEDP is so high that it's prizing open your
Sure.
aortic valve in diastole. That's like another sign that they might show you. This is just showing some of that. So we've got premature closure again here. This is all severe. You've got hollow diastolic flow reversal. Just to recap that, this is someone with a really severe jet, really dense, the same density as what's going forward, super steep pressure half time, premature closure. So if you saw all of these, without even seeing any moving pictures, you should be able to pick that this is someone with severe AR. These are all the features that they want you to say when they're like, give me some echo features of acute AR. LV is not dilated. You often have a hyperdynamic function, increased LVOT VTI, that premature closure, diastolic MR, high filling pressures. Your decel time for your mitral inflow is often really short, right? Because you've got that really high LVEDP. And then you might get that early termination of the diastolic flow. So I'm not going to go on to management. We kind of talked about it, right? So in chronic AR, obviously you need to recognize it first and foremost, and then you're going to try and avoid excessive afterload. Things that we do like NORAD and stuff might worsen that regurgitant fraction. And you're going to obviously want to keep their lungs as dry as possible because their filling pressures are going to be high. So you want to be mindful of that and not do anything to tip them over with that or dry them out if they need it. And then acute AR, as I said, tends to be you need to see what the mechanism is, and it's usually dissection or endocarditis when it's acute and severe, and then work that out from there. And then I just want to show you some cases. So do one of you want to go? If you could please leave if you need to. I need to leave soon, but I'm good for like another 15 minutes or so. If you want to stay on and practice. Maybe if there's any of you that are doing your vivas soon, you might want to go through this one and practice. Hey, Ron, do you want to take it?
Yeah, that'd be great.
Yeah.
Yeah, sure. So 87-year-old who's coming with non-STEMI past medical history of bioprosthetic AVR, ischemic heart disease and frailty, cardiac shock during coronary angioplasty, and left main and circumflex has been stented. Patients intubated on inotropes and IABP, and progressive escalation of inotropes over the next 4 hours.
Sorry, this is a balloon pump tracing showing lack of augmentation. This wouldn't be in the exam, and you'd get more context with that. So there's no augmentation of the balloon pump.
Okay. Forgot all of my stem now. But no, it's all right. So it's a parasternal.
Sorry, I'll just remind you. So non-STEMI, 2 stents, history of biprosthetic AVR, escalating pressure requirements, balloon pump in.
So parasternal long axis view. Again, just going through systematically, the LV function appears hyperdynamic. Both the anteroseptum and infralateral walls are contracting normally on this view. LV size, it does not look significantly enlarged, but I like to confirm it with measurements. RV, again, not much abnormalities there. Mitral valve, the anterior leaflet appears a bit thickened, perhaps some restricted opening. The aortic valve, again, it's about like the appearance is consistent with bioprosthetic prosthesis. I can't see much of the ascending aorta, but there's nothing to suggest dissection flap on this view. Other thing I should mention is the LA looks significantly dilated.
Okay, I'm just going to take you through. We'll come back. All right.
Like on collar flow Doppler, there's a significant like regurgitant jet across the aortic valve with aliasing, or like there's also central mitral regurgitation on collar flow Doppler, and I'd like to interrogate that further. This is continuous wave across the aortic valve on apical 5-chamber view with very short pressure half time, suggestive of severe aortic regurgitation. I think both the collar flow Doppler and the pulse wave in the descending aorta consistent with hollow diastolic flow reversal, and I think the velocity is greater than 0.2.
All right, so putting it together, how would this, what do you, if you could summarize it in a sentence or two, and how would this change your immediate management for this patient?
So this patient developed what looks like an acute severe aortic regurgitation post coronary angioplasty, which could be iatrogenic secondary to the procedure. I think the management implication is firstly the intra-aortic balloon pumps now contraindicated and will need to be stopped and removed, and then I'll sort of break it down to a definitive treatment for this would be urgent surgical repair, and then supportive therapy in terms of decreasing the afterload. Very supportive management would revolve around decreasing the afterload and also managing the likely raised LV end diastolic pressure and resultant pulmonary edema.
Yeah, very nice. So your usual sort of management there, but the key thing, taking that balloon pump out, which as you clearly said, is now contraindicated, which is beautiful. I don't know really how to interpret the descending aortic flow, like when you've got a balloon pump in there, you know, like putting it back. But I think that's where these sharp spikes are coming back from. And you can see some holodiastolic, like some flow reversal and diastole. And you can certainly see all that turbulent, awful diastolic flow coming back. But, you know, you've got the balloon pump in there as well. So it makes it, just clouds it, doesn't it? But I do want to come back just to your, so I think you did well, like your cadence was good and things, but I just want to give you a few tips for maybe how you could, you know, like improve it for next time, because it's a little bit like when, you know, obviously when we started out for our fellowship training and stuff, like where you do your hot case and you're like pointing, like you're summarizing at the end and you're pointing everything out, but you're not bringing it together neatly. I think, you know, it's fine in the Viva because you're not going to have a really long time. You obviously need to have some system. But if you see like a rip-roaring abnormality, you need to just go straight to it. Otherwise, the examiner's like, oh my God, tell me about the aortic valve, which is what I was doing as you were telling me about the RV.
Okay.
And like, do you know what I mean? Like I was like, I don't really care about the RV too much here. Like, just tell me what the aortic valve is doing. And I do want to point out that there is an abnormality with this aortic valve that you know, that you didn't comment on, which is fair enough because you'd want to see it in more planes. But I would at least say that I was worried about this valve because you're right about the LV, you know, its function looks normal to hyperdynamic. You know, it doesn't look terribly dilated, but I'd want to quantitate that. The LA looks massive. You know, the RV I can't see very much of, but doesn't look terribly dilated. But the striking abnormality to me in this view, especially with this story, is that the aortic valve looks highly abnormal. I can see opacities that could be the cusps of the aortic valve potentially protruding into the LVOT. There could be some side lobe artifact with that, you know, from the thickening with the bioprosthesis. However, given the story, I definitely want to, you know, interrogate that in more views. Can you see that again as you're looking at it? You see how it's just sort of flicking into and there was actual damage to the you know the cusps of the valve, I think, from, you know, during the procedure, that obviously then got made worse from the balloon pump being in. And then I think you did reasonably well with this part. So you know, significant turbulence on color flow, with what looks like a very broad, you know, severe jet. I'd want to quantify that more, but it looks very concerning that this is significant and a severe, you know, probably because they want to sort of, you know, probably an acute aortic regurgitant process, given the, you know, the LV size and function, you know, in the clinical history, it's more in keeping with an acute process, maybe acute on chronic, you know, with this lady's history. But yeah, just saying how, and I think you did well with describing that. I mean, there's a little bit of MR, and I think it's actually systolic MR rather than diastolic, but you could slow that down and you could say, I just want to check that there isn't any diastolic MR there. That would be quite a nice thing to say, wouldn't it? Because but it looks like it's systolic because it's like not there when it's not there when you're, so you've got no MR when your AR is coming back through there. Anyway, small thing. And then nice about this, so really dense, really steep, continuous wave through in keeping with severe. And then you got through to that part. And then the key thing that they would want you to say is like, I want the balloon pump to come out, which is on the money, which is exactly what you said. So you would pass that STEM with what you just did there. I'm confident that you would pass that question, but just refining to like, come to the money a little bit sooner with that first like plaques view. But
thanks, Emma.
All right, there's another one that we could quickly go through. I've shown this one before, but if anyone wants to just take this one and comment on it, you can, or I can go through it. It's up to you. But it is quite a good one for those of you that haven't seen it before. I think I need to put some new cases in. Hey, come on to the next one. Anyone want to shout out a striking abnormality?
This is a parasternal long axis where the aortic root's been opened up. and there's a dilated aortic root, and there is also appears to be some abnormality in the root and potentially a flap in the root itself, but the main abnormality is a dilated aortic root.
Yeah, so this patient came in, she was a poorly controlled hypertensive diabetic with chronic kidney disease, 70, presented to ED breathless, no chest pain, but had this sort of wide pulse pressure, a little bit of oxygen, but wasn't too bad actually when she came in. So what do you want to do next with your echo? So you've seen this.
So I'd want, if possible, further views of the ascending aorta, and I'd also want to interrogate the aortic valve, which in 2D looks normal, but just to see if there's any degree of aortic regurgitation on color flow.
Yeah, very nice. I should say actually, prefacing this whole talk, this is, we've talked about dissections and echo. Obviously, your gold standard is always going to be CT angiography, if your patient's stable enough for that. Very nice. So we've got some color for you here.
So looks like there is aortic regurgitation. It's on eyeball, it looks roughly a moderate vena contractor, and it appears to be central, which is consistent with a dilated aorta.
Yeah, let me just slow that down, just to go through that. So there in diastole, you've got that flow convergence. It's sort of eccentric and chaotic and a bit all over the place, isn't it? It's filling a lot of the LVOT, like more than 65%. The vena contractor, as you said, does look broad, and you're worried about dissection, right? So you're thinking already that this is likely, it could be a AR associated with the dissection. Obviously, you're going to start looking for other things that you get with dissection. So you can get AR, you can get regional wall changes if you've dissected down into your coronaries. You can get pericardial effusions, you can get pleural effusions. So you'd be looking for those things as well. Like, just to complete the picture, I know we're focusing on the AR in this particular stem. Okay, what do we see here?
So this is a kind of a 5-chamber. The abnormalities are again seen. So there appears to be a dissection flap going across the ascending aorta. The aortic valve in this view doesn't look entirely normal. It might be off axis, but it looks like there's a degree of abnormal aortic valve motion and prolapse. The left ventricle itself in this view appears to be moving relatively normally as compared to the first view, where it appeared to be slightly dilated and more hyperkinetic.
Yeah, very nice. And that's a good thing to point out, because what you're doing here is you're tilting down anteriorly. So you're actually not cutting through the axis of the LV properly to comment on regional wall. So to comment on systolic function, because it doesn't look too bad there, does it? But in fact, this lady had moderate LV impairment because she had chronic heart failure as well with her comorbidities. But if we just go back to the initial parasternal, she's got significant LV impairment as well, and a big LA. So it's just the way that you're cutting through that on the 5-chamber, which is why we don't really comment on function so much in a 5-chamber, and that's why we do it in a 4, because you're cutting through like the more anterior part of the heart, so you get a false sense of security. Right, color on this too.
So compared to the parasternal long axis, this looks much more pronounced. So there appears to be a torrential jet of aortic regurgitation. It's a very wide, turbulent blood flow. So this looks bad. Yeah, and this is consistent. So there is a steep, dense jet and almost unmeasurable pressure half-time. So there is bidirectional flow, there is regurgitant flow in the abdominal aorta on the right side. It doesn't fully fill the aorta. I wonder if we're seeing a degree of the flap there as well.
Yeah, I think we've got the true lumen and then the false lumen, so the expansile true, and then the blood coming in the true there, and then flowing through the little entry points at multiple parts into that false lumen. So seeing the flap there. So differentiating true from false, we've run out of time, but is a thing that they could ask you to do in the exam. Pretty
And yeah, and there's hollow diastolic flow here in the, is this a suprasternal notch? And
very
so
nice.
just after the so it's not actually, so there does appear to be hollow diastolic. It tails off a bit towards the end, but there does seem to be significant diastolic flow of 0.2 meters per second.
Yeah, how might you are you completely happy with this? Like if you were going back to if you were doing it yourself, what might you have done different with this trace?
Pass.
So probably where the gate is, it's probably not in a perfect spot. Like it's probably just at the level of the brachiocephalic. It needs to be like just distal to that. Also because I think you've got such low flow blood, like she is obviously getting unwell by this stage, like you're not getting too much forward flow. And so you've got really low velocity blood coming through actually. And that's why you've got all this dropout happening at your baseline and things. So you could reduce the low pass filter just to fill that in a little bit. And then just try and optimize that Doppler angle, maybe just bring it down a little bit more into the descending. You might get a bit of a better trace with that. And these are the challenges, right? When people are sick and unwell, like an acute AR in particular, there are all these challenges that make it different from someone coming to your clinic where you've got chronic AR and things. This was her toe, and for time I might just go through. So very nicely spotted that dissection flap in the ascending aorta, and then she does have some prolapsing of the valve as well, leading to severe aortic regurg. So with dissection, these are the different ways that you can get AR. You can either just dilate up your root, so you get a failure of coaptation because you've got like your big blood lumen like filling your lumen, and you just stretch the annulus, or you can actually get prolapse of one of the leaflets, or you can get flail of one of the leaflets, or you can actually get a little bit of the sort of material from the flap and intima sort of protrude through as well. All of these, lead to the AR that we sometimes see in type A dissections. And that's it, guys. I've got a few more just to go through there, but I think we've gone through quite a lot already. Thank you very much for listening. I think I've said all of this as we've gone through, but if anyone has any questions, happy to take questions or go back to any cases that you might just want to look at again. Yeah, or you might just want to leave because I've been talking far too long, and that's also good. All right, next time we'll
Emma, on a separate session, could we just do something? I'll have a look myself as well, but just something on how the raphe look when they're open and closed with different fusions.
With different types of BAV?
With different types of fusions of different raphes, just like,
definitely.
The diagram's great, but just in terms of how it looks in different open.
Yeah, definitely. I'm sure we can dig out some left and right and non, left and non. That's what you mean, right? Like different types of BAV. Yeah. Awesome. We'll have all of those somewhere. I think I've probably got them. Yeah, that's easy. Cool. All right. Take care, everyone. Thank you for listening. Okay, bye.